Welcome to the Deep Dive. Today we're plunging into a topic that touches millions of lives globally, the surgical management of obesity. When you consider the sheer scale of the global obesity pandemic, its severity, and the increasing reliance on surgical solutions, understanding this complex medical field like an elite professional becomes incredibly important. We're drawing our insights from foundational knowledge, specifically the chapter on the surgical management of obesity in SCHWARTZ's Principles of Surgery, penned by Anita P. Korkulis and Philip R. Schauer. Our mission in this deep dive is to equip you with a comprehensive, expert-level understanding of bariatric and metabolic surgery, from its earliest forms to the most cutting-edge research, so you can truly grasp the profound nuances of this dynamic field and feel well-informed.
And what's truly remarkable about this field is how rapidly the evidence for these procedures has grown, especially over the last decade or so. This swift accumulation of robust short and long-term data on their safety and efficacy has, fundamentally reshaped how patients and providers approach treatment. It has moved us definitively towards a well-informed, shared decision-making process, acknowledging the significant trade-offs involved, between the potential risks and the often remarkable benefits these procedures offer. Our aim today is really to go beyond the surface, uncovering the why it matters behind every significant development and allowing you to master this complex information.
Okay, so to truly understand where we stand in obesity management today, we really need to trace its history. It's a journey marked by groundbreaking ideas, unexpected challenges, and, constant adaptation. So where did the first surgical attempts at weight loss begin, and what crucial lessons did we learn from those early, sometimes pretty problematic procedures?
Right. If we go way back, the initial operations for severe obesity actually began in the 1950s. And interestingly, these were primarily designed not just for weight loss, but actually to treat severe hyperlipidemia. That's, dangerously high levels of fats in the blood, which was often associated with extreme obesity. The procedures, known as ileocolic bypass operations, had a pretty straightforward goal: limit nutrient absorption by bypassing a significant portion of the intestine. But there was a critical flaw. These early attempts came with severe, even life-threatening nutritional complications and liver failure after surgery. It quickly became clear that these issues were just, far too severe to continue.
Wow, this sounds like a truly challenging start. So how did the surgical community respond after such dire experiences with those intestinal bypasses?
Well, those severe complications led to a more, let's say, conservative procedure, the jejunal bypass. This was still a malabsorptive operation, but it bypassed only a portion of the small intestine, hoping to mitigate the previous extreme side effects. Unfortunately, while perhaps less devastating, this procedure still resulted in, severe diarrhea, profound electrolyte disturbances, protein-calorie malnutrition, kidney stones, and ongoing liver failure. The complications, though possibly reduced, were still substantial enough that they demanded a fundamental reevaluation of the whole approach. The lesson was stark. Extreme malabsorption just carried unacceptable risks.
And that's where the focus shifted dramatically, right? The concept of actually modifying the stomach itself came into play, moving away from purely intestinal bypasses. How did this new paradigm emerge, focusing on gastric procedures?
Precisely. A pivotal shift occurred in 1969 when Mason and Ito performed the first true gastric bypass. Their technique involved creating a small gastric pouch, then connecting a loop of the jejunum that's a part of the small intestine directly to it. This was innovative, no doubt, but this initial design had a significant drawback. Severe bile reflux esophagitis became a major issue for patients. This complication really spurred further refinement. Just 8 years later, in 1977, Griffin and colleagues introduced a crucial modification, the Roux-en-Y reconstruction. This elegant solution was specifically designed to address and alleviate that severe bile reflux. And at the same time, the gastric pouch itself was changed from a transverse orientation to a vertical one, using the upper lesser curvature of the stomach. This vertical pouch in the Roux-en-Y configuration became, foundational for future gastric bypass procedures.
So if we look at the big picture here, we saw a clear evolution from extreme malabsorption to a new emphasis on gastric restriction, aiming to limit food intake. What happened with that restrictive approach, especially with operations like the vertical banded gastroplasty?
Right. The 1980s saw the rise of the vertical banded gastroplasty, or BBG, which Mason first performed in 1980. It was conceived as a purely restrictive operation. It created a stapled proximal gastric pouch with a restrictive band at its outlet. And initially, it seemed pretty promising, actually. It delivered significant initial weight loss, often 50% or more of excess weight, with remarkably low morbidity and mortality. This led to its rapid popularity, becoming the most commonly performed bariatric operation in the U.S. throughout throughout the 1980s. However, by the early 1990s, the limitations became starkly clear. Patients, resourceful in their struggle with obesity, found ways to adapt their diets by consuming high-calorie soft foods and liquids. This unfortunately led to significant weight regain for many. Furthermore, the procedure had inherent technical issues like stenosis at the band's cuff and staple line disruptions. Ultimately, its long-term weight loss outcomes proved poor. This outcome led to a definitive shift. By the 1990s, the Roux-en-Y Gastric Bypass had reestablished itself as the procedure of choice in the United States. The VBG taught us a crucial lesson. Simply stapling the stomach isn't enough. The body adapts, and we needed procedures that offered more profound and durable changes.
It's truly fascinating how surgical trends respond to real-world patient outcomes and, evolving scientific understanding. Beyond the VBG, what other key innovations and procedures emerged during this period, especially with the dawn of laparoscopic surgery?
Well, while VBG was having its moment, other procedures were also being developed. In the early 1980s, for example, Scofinaro in Italy developed and popularized the biliopancreatic diversion, or BPD. This was a complex procedure, later modified to include a duodenal switch, or DS. Today, the BPD with duodenal switch is notable as the only major malabsorptive operation still commonly in use, which highlights its unique, albeit demanding, efficacy. Then came the 1990s, which really brought a revolution, the widespread adoption of laparoscopic surgery. This minimally invasive technique transformed the field. The first laparoscopic adjustable gastric banding, LRYGB, was performed by Belishu in 1994, gaining rapid popularity in Europe and Australia before U.S. approval in 2001. That same year, 1994, Whitgrove and Clark performed the first laparoscopic Roux-en-Y Gastric Bypass, and in the post-2008 era, we saw an incredibly rapid rise in Sleeve Gastrectomy, SG, as a primary bariatric operation, quickly becoming one of the most performed procedures globally. This brings us to the current state of the field. What we've seen globally is a rapid adoption of laparoscopic sleeve gastrectomy, with a simultaneous dramatic decrease in LRYGB use. In 2014, SG accounted for nearly half of all procedures worldwide, followed closely by RYGB, with LRYGB significantly trailing. There are regional differences, of course, but the trend towards SG is pretty clear. Beyond just weight loss, a critical shift has occurred. A move from purely bariatric surgery to metabolic surgery, especially for type 2 diabetes. This is driven by compelling, high-quality data proving its efficacy, even in less severely obese patients. And perhaps most profoundly, our understanding of how these surgeries work is shifting. The old, simplistic, restrictive versus malabsorptive labels are being replaced by a much deeper focus on the basic physiological and metabolic mechanisms involved, like how ghrelin, leptin, GLP-1, and biocids are affected, and changes in gut microbiota. In the future, the very descriptions of these procedures will likely be based on their specific physiological impact, not just their anatomical features, which is, a key insight for any professional in this field.
Okay, before we delve deeper into the surgical intricacies, let's firmly establish what we mean by obesity and fully grasp its alarming scale globally. This foundational understanding is really crucial.
Absolutely. The numbers tell a sobering story. Worldwide, the prevalence of obesity has more than doubled since 1980. As of 2014, nearly 40% of adults globally were overweight, and a significant 13% were classified as obese. And this isn't just an adult problem. An estimated 41 million children under 5 were overweight or obese that same year. What's particularly concerning is that obesity is now on the rise even in low and middle income countries, especially in urban areas. Consider this. A staggering 65% of the world's population now lives in countries where overweight and obesity are linked to more deaths than underweight and malnutrition. In the United States, obesity is the second leading cause of preventable death in adults, only behind tobacco. When we define obesity, the most widely accepted method is by body mass index, or BMI, calculated as weight in kilograms divided by the square of height in meters. The World Health Organization classifies a normal BMI between 18.5 and 24.99 kilobarons or greater. Overweight starts at 25 kilobarometers order, with categories extending to obese class 3 at 40 kilobarometers or greater. It's important for professionals to note that for Asian populations, public health intervention thresholds are often set at lower BMIs, like 23 or 27.5, recognizing differences in body composition and risk. For children and adolescents, obesity is defined by BMI for age relative to growth references. At its core, the fundamental cause of obesity is an energy imbalance, consuming more calories than are expended. Globally, this trend is fueled by increased intake of energy-dense, high-fat foods and a simultaneous decrease in physical activity due to sedentary work, changes in transportation, and urbanization. These shifts are deeply rooted in societal and environmental changes, and unfortunately, there's a significant lack of supportive policies in critical sectors like health, agriculture, and education to counteract these forces. It's also important to recognize that the American Medical Association officially recognized obesity as a disease in 2013, emphasizing its multifactorial nature, driven by both environmental and genetic factors. This recognition is critical for how we approach treatment.
It's clear this is a complex global public health crisis. Let's focus on the U.S. prevalence specifically and dive deeper into that intricate interplay of genetic and environmental factors that contribute to this widespread disease.
Right. In the U.S., the 2013-2014 NNA's data showed adult obesity at nearly 38% overall, with women at 40% and men at 35%. Class 3 obesity, the most severe category, stood at 7.7% overall, disproportionately affecting women. Trends from 2005-2014 indicated significant increases in overall and class 3 obesity for women, but, interestingly, not men. For children and adolescents, obesity affected 17%, with extreme obesity at 5.8%. These are worrying numbers. Now, regarding the causes, while environmental factors are major drivers, not everyone exposed to the same environment becomes obese. This strongly suggests a significant genetic component. Twin, family, and adoption studies indicate a high heritability for BMI, ranging from 40% to 70%. We've even identified rare single gene forms of obesity like leptin or melanocortin-4 receptor deficiencies, which control energy balance in the brain. In fact, certain mutations in the melanocortin-4 receptor gene account for 2% to 5% of severe childhood obesity. This highlights a complex gene-environment interaction at play. One key insight for professionals is that when individuals attempt weight loss through diet or exercise, the body often triggers counter-regulatory responses. This means a reduction in resting energy expenditure and an increase in appetite and food intake, which can unfortunately limit the degree of weight loss and make long-term maintenance very difficult. From a cellular perspective, obesity involves an excessive number and size of fat cells. While cell number can be determined early in life, adult-onset obesity is mostly due to existing fat cells growing larger. However, substantial weight gain can lead to an increase in both the size and number of these cells. It's also important to consider fat distribution. Men typically store fat around internal organs known as central visceral fat, while women more often have peripheral fat. This distinction is clinically significant because central or visceral fat is strongly linked to metabolic diseases like diabetes, hypertension, and metabolic syndrome. This nuanced understanding of genetics, physiology, and fat distribution is critical for effective management.
Beyond the immediate health concerns related to weight itself, it's vital to emphasize the wide-ranging concurrent medical and social consequences that profoundly impact a patient's life and overall well-being. I mean, this isn't just about weight on a scale, is it?
Oh, absolutely not. It's absolutely not just about the number on the scale. The ramifications of elevated BMI extend far beyond simple weight, acting as a major risk factor for a host of serious diseases. We're talking about cardiovascular diseases like heart disease and stroke, diabetes, osteoarthritis, and several types of cancer, including endometrial, breast, ovarian, prostate, liver, gallbladder, kidney, and colon cancers. The risk for these conditions demonstrably increases with higher BMI. Childhood obesity, tragically, is a strong predictor of adult obesity, premature death, and disability. Even in childhood, it brings immediate health challenges such as sleep apnea, increased fracture risk, hypertension, early markers of cardiovascular disease, insulin resistance, and significant psychological effects. For patients with severe obesity, the clinical picture is often one of multiple chronic and debilitating weight-related problems known as comorbidities. This includes conditions like degenerative joint disease, persistent low back pain, hypertension, obstructive sleep apnea, OSA, gastroesophageal reflux disease, GERD, gallstones, type 2 diabetes mellitus, dyslipidemia, asthma, hypoventilation syndrome of obesity, and even right-sided heart failure. Less commonly recognized, but still significant, are migraine headaches, pseudotumor cerebri, venous stasis ulcers, deep venous thrombosis, various fungal skin rashes and abscesses, stress urinary incontinence, infertility, dysmenorrhea, and depression, along with large abdominal wall hernias. It's a truly comprehensive list of interconnected health challenges. Thinking like a professional, it's about understanding the pathways through which excess fat drives these diseases. For instance, while most fat is stored just under the skin, visceral fat, the fat around organs, is mechanistically linked to many severe metabolic disturbances. Fat around the kidneys can even contribute to hypertension by compressing the renal parenchyma. Increased soft tissues in the pharynx lead to OSA. The sheer mechanical load from excess weight directly causes osteoarthritis in joints. Elevated intra-abdominal pressure contributes to increased risks of GERD, Barrett's esophagus, and even esophageal cancer. Chronic overactivity of the sympathetic nervous system also contributes to high blood pressure. And beyond the physical, obesity is profoundly associated with increased depression, anxiety, body image disturbance, and a significantly decreased quality of life. In fact, many patients seeking surgery do so as much for the profound impact on their quality of life as for the medical issues.
Given the profound and wide-ranging health consequences of obesity, it's clear that intervention is crucial. So if surgery is a deep dive, what are the other ways we've tried to tackle this massive health challenge? What does the non-surgical landscape of obesity management look like?
That's a critical question. Surgical intervention is part of a broader spectrum of care, and treatments for obesity should always align with the condition's severity, associated comorbidities, and the individual's functional limitations. Broadly, there are three main evidence-based options: lifestyle intervention, pharmacotherapy, and bariatric surgery. Lifestyle interventions are typically the first step, given their low cost and minimal risk. The core is behavioral therapy, teaching patients practical techniques for healthier eating and increased physical activity. This often involves regular recording of food intake and activity, with weekly reviews with a trained professional. These programs generally lead to about 5% to 8% mean weight loss of initial body weight, with many achieving at least 5%. The Look Ahead study, a large randomized trial, showed significant results. At 1 year, an intensive lifestyle intervention group lost an average of 8.6% of initial weight, far outperforming a control group. This also led to improved cardiovascular risk factors and glycemic control, and these benefits were largely maintained at 4 years. However, and this is a crucial insight for professionals, despite these significant improvements, the intensive lifestyle intervention did not reduce morbidity and mortality from cardiovascular disease after nearly a decade. The study was actually stopped early because it wasn't achieving its primary cardiovascular endpoint. So while lifestyle interventions are viable, they often struggle to achieve durable weight loss beyond 5% to 10%, and so far haven't directly improved cardiovascular outcomes. Nevertheless, they remain indispensable adjuncts to bariatric surgery. Moving to pharmacotherapy, medications are an important addition to lifestyle changes for adults with a BMI of 30 or higher, or a BMI of 27 to 29 with at least one obesity-related condition. These medications, when combined with lifestyle, lead to additive weight losses. We now have 5 newer FDA-approved medications for long-term use. Single drugs like orlistat, lorcaserin, and liraglutide show about 6% to 9% total weight loss in 1-year trials. Combination drugs like phentermine topiramate and naltrexone bupropion show similar ranges, acting on neural weight loss mechanisms. When compared to placebo, the higher dose phentermine topiramate combination adds roughly 9% to initial weight loss at 1 year, and 67% to 70% of patients achieved a clinically meaningful 5% weight loss. A key limitation here is that none of these medications, with some emerging data for liraglutide as a possible exception, have definitively shown a reduction in cardiovascular morbidity or mortality. Long-term safety and efficacy data are still limited, and some drugs have side effects. So while these medications do lead to greater weight loss than lifestyle alone, they are often underutilized, largely due to patient disappointment with perceived moderate weight loss, significant costs, ongoing safety concerns, and the reality of weight regain once medications stop.
This raises an important question for the field. If we have these seemingly effective non-surgical options, why aren't more people, especially those with severe obesity, benefiting from them? What are the significant barriers to treatment access and uptake?
That's a critical paradox. Despite these evidence-based medical treatments and the proven efficacy of bariatric surgery, only a very small fraction of indicated patients ever pursue or receive them. Some estimates suggest less than 1% of individuals with severe obesity who could benefit from surgery actually undergo it. It's quite low. There are multiple interconnected barriers. First, many healthcare providers have been slow to recognize that obesity is a chronic disease requiring long-term management, not just a lifestyle choice. Compounding this, many physicians receive inadequate training in nutrition and obesity. Limited insurance reimbursement for the full spectrum of obesity treatments also plays a significant role, often making long-term care financially prohibitive. Furthermore, there's a scarcity of effective and widely accessible lifestyle programs, which are foundational. Finally, there's a noted lack of appropriate referrals of patients with severe obesity to experienced bariatric surgeons, and a general lack of knowledge among both patients and some providers about the highly positive recent outcomes of bariatric surgery. These factors together create a formidable hurdle to widespread effective treatment.
So for those who do consider surgery, who are the right candidates, the criteria for eligibility have evolved significantly over time, especially with the growing understanding of metabolic benefits beyond just weight loss. What are the current indications and, equally important, the contraindications?
You're absolutely right. Patient selection has indeed shifted considerably, reflecting our deeper understanding. The Centers for Medicare and Medicaid Services, or CMS, define the standard approved procedures, though coverage for sleeve gastrectomy can vary by regional carriers. The foundational criteria for patients with Class 2 and Class 3 obesity still largely align with the National Institutes of Health, NIH Consensus Conference of 1991. These state that surgery is indicated for individuals with a BMI of 40 kilograms or greater, or a BMI of 35 kilograms or greater with at least one obesity-associated comorbidity. A crucial additional requirement is the failure of previous non-surgical weight loss attempts, even professional-guided ones. And finally, patients must demonstrate a strong commitment to postoperative care, including lifelong follow-up and supplements. However, a significant expansion of these indications came with the 2016 Second Diabetes Surgery Summit, DSS-2, guidelines. These advocates that metabolic surgery should also be considered for patients with type 2 diabetes mellitus and a BMI of 30 to 34.9 kilometer, what we call class I obesity, if their blood sugar is inadequately controlled despite optimal medication. For Asian populations who often experience health risks at lower BMIs, these guidelines recommend reducing the BMI threshold by 2.5 kilograms. Regarding age, the NIH criteria don't set specific limits, leading to varied surgical practices. The pediatric obesity epidemic means more young patients are eligible, and emerging data suggests that earlier intervention may lead to better reversal of comorbidities compared to adults. There's also the promise of longer postoperative benefit in terms of improved quality of life and prevention of the emotional, social, and physical consequences of obesity. Conversely, older patients, especially those over 65, often have more comorbidities. While surgery can offer immediate quality of life benefits, recovery from complications can be impaired. Interestingly, some studies show increased mortality in very elderly patients, while others, like a 2016 Utah study, found LRYGB to be protective against mortality even for older patients. So, the picture for older patients is nuanced and requires careful consideration. As for contraindications, there are clear medical issues. These include extremely high surgical risk, ASA Class 4 disease, psychological instability, or an inability to fully comprehend the implications of surgery and its required lifestyle changes. Active drug or alcohol addiction is an exclusion. Tobacco use must be avoided, with smoking cessation required at least 6 weeks prior to surgery, as it significantly increases risks of poor wound healing and anastomotic ulcers. A poorly controlled eating disorder, particularly bulimia, is also a contraindication. Being non-ambulatory is a relative contraindication due to increased surgical risk and challenges with self-care. Finally, a lack of sufficient social support or a profoundly unsupportive home environment can also be contraindications, as these factors are critical for optimizing long-term outcomes.
Right. So we used to categorize these surgeries as simply restrictive limiting food intake or malabsorptive limiting nutrient absorption. But modern science tells us it's far more complex now. How has our understanding of how these procedures truly work evolved beyond those basic anatomical classifications?
That's a crucial evolution in the field. We don't yet have one clear, universally accepted understanding of precisely how each bariatric procedure achieves its effects on weight loss, metabolism, and blood sugar control. It's an intensely active area of research, constantly revealing new insights. One key insight is that neither laparoscopic Roux-en-Y Gastric Bypass, LRYGB, nor sleeve gastrectomy, SG, are primarily restrictive procedures. There are profound changes in both behavior and physiology after surgery that fundamentally help maintain the new, lower body weight changes simply not observed with non-surgically induced weight loss. Laparoscopic adjustable gastric banding, LAGB, however, does appear to be more dependent on gastric restriction, as its effects on gut hormones are less dramatic. Secondly, both LRYGB and SG lead to metabolic improvements that go beyond what can be attributed to weight loss alone. These complex mechanisms are under active study. For LAGB, conversely, the metabolic effects are largely a direct result of the weight loss achieved. This deeper, nuanced understanding has moved us decisively away from the older, simplistic restrictive versus malabsorptive classifications. Earlier theories, like the foregut hypothesis for LRYGB, suggested improvements came from bypassing the upper small intestine, reducing nutrient-dependent hormonal actions that impair glucose tolerance. The hindgut hypothesis proposed that rapid nutrient delivery to the distal small intestine was key, increasing GLP-1-QYY secretion. However, the consistent metabolic effects of SG, which doesn't bypass the foregut or induce distal nutrient delivery, challenge these distinctions and push research to explore other, more profound physiological mechanisms.
Okay, let's unpack this further. Given that shifting understanding, what exactly are the nuggets of knowledge about how these surgeries lead to weight loss? What are the specific, multifaceted mechanisms at play?
The mechanisms are indeed multifaceted and interconnected. One obvious component, especially for LRYGB, is reduced caloric intake and some malabsorption due to the smaller gastric volume and bypass of the proximal small bowel. For LAGB and SG, gastric restriction certainly contributes to reduced food intake early on. But beyond these anatomical changes, profound physiological shifts occur. Surgeries can alter food preferences and influence energy expenditure. Gastric emptying and insulin sensitivity often improve after LRYGB and SG. Brain imaging studies have even shown decreased neuronal activation in food reward centers of the brain after RYGB in response to high-calorie foods, suggesting a fundamental shift in how the brain processes food cues. Neural signaling is also altered. Changes in vagal nerve endings in the new gastric pouch and Roux limb may contribute to early satiety. Hormonal changes are critical. While ghrelin levels can be conflicting, other hormones show clearer patterns. GLP-1, a postprandial hormone, significantly increases after RYGB and SG. PYY, another postprandial hormone, also increases after RYGB and SG. Leptin levels appear lower than expected for the new body weight in RYGB and SG cases, potentially indicating improved leptin sensitivity. A rapidly expanding area of research is the role of the gut microbiota. Obese individuals have distinct gut flora. Following gastric bypass, this composition shifts, and interestingly, bacterial transplants have even shown some benefits of gastric bypass. Bile acids are another key player. Serum bile acid levels increase after gastric bypass, and their diversion activates specific receptors that promote GLP-1 secretion and regulate lipid glucose metabolism, leading to rapid triglyceride clearance. SG also increases circulating bile acids. Finally, there are noticeable changes in dietary patterns and food tolerance. RYGD and SG are linked to decreased fat intake and more fruits and vegetables, while LAGB is associated with increased caloric liquids. In summary, it's a complex, still not fully characterized relationship between dietary changes, bile flow, altered hormones, and gut microbiota, all working together for weight loss.
If we connect this to the bigger picture, the profound impact of these surgeries on type 2 diabetes is truly remarkable, almost bordering on a cure for some. How exactly does this metabolic transformation work? What are the mechanisms behind such a powerful effect?
The ability of bariatric surgery to profoundly improve and often resolve type 2 diabetes is indeed one of its most remarkable aspects, leading to the coining of the term metabolic surgery. The global diabetes pandemic has been staggering, and without intervention, T2DM typically involves progressive beta cell failure and severe complications. So, metabolic surgery has truly emerged as a pivotal tool for controlling hyperglycemia. Historically, over 2 decades ago, researchers observed that bariatric surgery rapidly normalized blood glucose levels in obese patients with T2DM, with many remaining disease-free for a decade. While caloric restriction plays a role, other factors like exclusion of nutrients from the proximal intestine, rapid nutrient delivery to the distal gut, and gut hormones were hypothesized. These findings have now been widely replicated, and there's compelling evidence that surgery can prevent or delay the onset of new T2DM cases. The specific physiological mechanisms are still incompletely understood, but are a major area of intensive study. Leading hypotheses include changes in bile acid metabolism, altered nutrient sensing, and glucose utilization within the intestines, intestinal adaptation, the powerful role of incretins like GLP-1, and significant shifts in the intestinal microbiome. These intricate changes collectively lead to several critical outcomes: reduced glucose production by the liver, increased glucose uptake in tissues, improved insulin sensitivity, and enhanced beta cell function. It's highly probable that a combination of these factors acting together is responsible for the rapid and sustained postoperative glycemic improvement. Active research, including genomic and gut microbiome studies, continues to deepen our understanding with the hope that this insight will lead to less invasive treatments that can achieve similar benefits.
Right, for the patient, this isn't a spur-of-the-moment decision. It's a truly significant undertaking. What does the comprehensive journey look like before surgery, encompassing all the necessary evaluations and preparations?
You're absolutely right. Bariatric surgery is the culmination of an extensive multidisciplinary evaluation process designed to optimize outcomes and mitigate risks. This involves a thorough assessment for obesity-related comorbidities and the underlying causes of a patient's obesity. A core component is input from a nutritionist. This involves an independent evaluation of the patient's eating habits, nutritional knowledge, and motivation to genuinely change. At least one assessment and an educational session are provided preoperatively, tailored to the specific nutritional counseling required for the chosen procedure. Psychological assessment is also standard. A primary goals are to identify any contraindications, like poorly controlled psychiatric illness or active substance abuse, and to help identify strategies that will support long-term weight management. These evaluations typically involve in-depth interviews and questionnaires. One of the most prevalent and often undiagnosed issues among candidates is obstructive sleep apnea, OSA, affecting over 90% of candidates. Given OSA's association with increased mortality and adverse outcomes, routine preoperative screening with polysomnography is highly recommended, and standard management includes CPAP. Other pulmonary diseases, like asthma and hypoventilation syndrome, also require careful preoperative management. Preoperative weight loss, while not always mandatory, is often encouraged. Even a 10% total body weight loss has been linked to a reduction in liver size, which can significantly improve the technical aspects of surgery, especially for patients with extreme central obesity. Optimizing preoperative blood sugar control is vital, using diet, activity, and medications to reach targets like an HbA1c below 7%. For patients with active GERD, a preoperative screening upper endoscopy is recommended to rule out Barrett's esophagus or other issues, as these areas become difficult to inspect postoperatively. The presence of Barrett's esophagus is a specific contraindication for sleeve gastrectomy, as it can worsen reflux. For women of reproductive age, pregnancy should be avoided for 12 to 18 months post-operation. Comprehensive counseling on appropriate weight gain, nutritional supplementation, and fetal health is provided for those who become pregnant. Finally, extensive patient education, including materials and sessions, is provided. The informed consent process itself is a thorough discussion covering risks, benefits, procedural options, and the critical need for lifelong follow-up and vitamin supplementation.
That's an exhaustive process covering every angle of the patient's health. What are the specific anesthesiology considerations for severely obese patients undergoing these complex surgeries? It must present unique challenges.
It absolutely does. Anesthesiology for the severely obese patient presents several distinct challenges. Two of the most significant are achieving reliable vascular access and meticulous airway management. For difficult airways, specialized techniques like fiber optic laryngoscopy or videotelescopic intubation systems are often employed. Critically, these patients require significant preoxygenation, often for 3 minutes or longer before intubation, to provide a longer safe duration in case intubation difficulties arise, as they do not tolerate desaturation well. During laparoscopic procedures, the anesthesiologist must also manage the alterations in cardiopulmonary function caused by inflating the abdomen with gas, known as pneumoperitoneum. This includes the effects of carbon dioxide absorption requiring increased ventilation and the potential for slowed heart rate. Longer procedures, especially in patients with pre-existing heart or lung disease, can also lead to decreased systemic pH, potentially requiring arterial monitoring. Drug pharmacokinetics are also significantly altered. Changes in drug distribution, less total body water, more adipose tissue, and altered protein binding all play a role. The anesthesiologist must consider potential alterations in kidney and liver function when dosing medications. On a positive note, enhanced recovery after surgery, or ERS, protocols are increasingly used in bariatric surgery. These guidelines encompass recommendations for pre, intra, and postoperative care, including using shorter-acting anesthetic agents and minimizing opioids, showing great promise in decreasing surgical morbidity and even reducing hospital stay. Finally, the entire hospital and clinic infrastructure needs to be specifically equipped for bariatric patients. This means extra-wide doorways, specialized seating, scales up to 800 pounds, larger gowns, appropriately sized blood pressure cuffs, and floor-mounted toilets. In the operating room, surgical tables must accommodate heavy weights and steep positioning. Surgeons also require specialized instruments like angled telescopes and extra-long graspers. Beyond equipment, staff sensitivity training and regular education on complications are fundamental to ensure safe and respectful care.
Now let's get into the mechanics. We've seen how the field evolved from rudimentary techniques. What are the key surgical procedures currently performed, and how do their fundamental techniques and nuances differ from one another?
Right. The surgical landscape has dramatically changed. Vertical banded gastroplasty, VBG, is now mostly of historical interest. Our focus is on current dominant methods, primarily the laparoscopic approach, which is standard due to advantages in minimizing incisional problems, enabling earlier discharge, and reducing 30-day complications. Laparoscopy begins with safely creating a pneumoperitoneum, which can be challenging in bariatric patients. Techniques like a Varus needle or Hassan approach are used, often requiring extra long long ports for thicker body walls. The robotic approach is also growing, offering potential ergonomic benefits. However, current meta-analyses show no significant differences in complications or length of stay between robotic and laparoscopic bariatric surgery, but robotic procedures still involve significantly increased operative time and higher hospital costs. Its precise role is still being defined.
Okay, let's delve into the laparoscopic Roux-en-Y Gastric Bypass, or LRYGB, which remains a cornerstone procedure. Can you explain its core technique and the most important complications associated with it?
Sure. LRYGB is generally appropriate for most eligible patients, though previous gastric surgery or severe iron deficiency anemia can be relative contraindications. The hallmark is creating a small proximal gastric pouch, then 20 milliliters, completely separated from the rest of the stomach. A segment of the small intestine, called the roux limb, is then brought up and connected to this small pouch. The lengths of the intestinal limbs are crucial. A biliopancreatic limb, typically 20 to 50 centimeters, and a roux limb, usually 75 to 150 centimeters long. Historically, longer roux limbs were thought to lead to more weight loss, but this isn't consistently seen long term. Pouch size, or the connection's caliber, also haven't been directly linked to overall weight loss. The core technique involves dividing the upper stomach to create that tiny pouch. Then the small intestine is divided, and one end, the roux limb, is brought up to connect to the new pouch. The other end of the small intestine is then reconnected lower down, forming a Y shape. All openings in the mesentery, which supports the intestines, must be meticulously closed with sutures to prevent internal hernias, a serious complication. Regarding complications, mortality is consistently very low, typically less than 0.5% in large series. Major adverse outcomes are also low. Specific complications include anastomotic leak. This is a serious issue, occurring in about 0.3% of cases, often presenting subtly with symptoms like rapid heart rate, rapid breathing, or fever. It almost always requires surgical repair and drainage. Marginal ulcers occur in 3% to 15% of patients, causing upper abdominal pain. They are usually diagnosed by endoscopy and treated medically, with surgery reserved for severe cases. Bowel obstruction occurs in about 7% of cases. Crucially, obstructions after LRYGB often require emergent surgical therapy due to the high incidence of internal hernias, which can quickly lead to bowel infarction. Anastomotic stenosis. Narrowing at the connection points, occurring in 1% to 19% of cases, typically presents weeks after surgery. It's usually treated successfully with endoscopic balloon dilation. Nutritional complications. Common long-term issues include iron deficiency, 66%, B12 deficiency, 50%, and vitamin D deficiency, at least 15%, often requiring lifelong supplementation. Dumping syndrome. This can occur after eating certain foods, causing symptoms like nausea, wetness, and sweating. Hematemesis, vomiting blood. In the immediate post-op period, this suggests bleeding from the new connection and requires immediate investigation. Biliopancreatic limb obstruction. Any signs of obstruction in the first few weeks demand immediate surgical intervention to prevent serious issues. The key takeaway for LRYGB is its effectiveness for weight loss and comorbidity resolution, balanced by the need for diligent long-term nutritional and surgical follow-up.
That's an incredibly comprehensive breakdown of LRYGB. Now let's shift to laparoscopic sleeve gastrectomy, or SG, which has seen incredibly rapid growth in popularity as a primary bariatric procedure. What are its unique aspects, from technique to specific complications?
Okay, laparoscopic sleeve gastrectomy, SG, initially served as the first stage of a two-stage operation for patients with superobesity, BMI over 60. Its efficacy and safety led to its rapid adoption as a primary single-stage procedure. However, patients with long-standing severe GRU may not be good candidates, as SG can actually worsen reflux due to the anatomical changes it creates. Barrett's esophagus is also a contraindication due to the risk of future esophageal dysplasia. The core technique involves reshaping the stomach into a slender, tube-like structure. This is achieved by meticulously devascularizing the greater curvature of the stomach and then stapling and dividing the stomach along a guide tube, a bougie, typically 32 to 40 French, removing about 80% of it. This process creates a sleeve that profoundly alters gut hormone signals in addition to limiting food intake. The staple line is then carefully inspected and sometimes reinforced. Now, regarding complications unique to SG, high-pressure gastric tube. SG creates a high-pressure gastric tube which places the staple line at risk for leakage and increases the risk of Gilyard staple line leak. Proximal staple line leaks are the most frequent, often related to increased pressure or stapling too close to the angle of his. These can present weeks or months after surgery. Distal leaks usually occur earlier and are more amenable to repair. Bleeding Overall bleeding rate from the staple line is around 2%. While staple line reinforcement is debated, some experts support its use for bleeding control. Sleeve obstruction stenosis most often occurs at a specific point in the stomach due to narrowing or twisting. This also increases leak risk. First-line treatment is endoscopic dilation, which is usually successful. Persistent leaks or stenosis may eventually require conversion to RYGB, persistent G or D. As mentioned, SG can worsen GER, and persistent severe reflux may also necessitate conversion to RYGB. The key takeaway for SG is that it offers significant weight loss and metabolic benefits with a generally favorable safety profile. However, its impact on GER and the unique considerations of the staple line make patient selection and follow-up crucial.
Okay, now let's discuss laparoscopic adjustable gastric banding, or LAGB, a procedure that has seen a significant decline in use. Despite its decreasing prevalence, understanding its mechanics and unique complications is still important for historical context and managing previous patients.
Indeed, LAGB involves placing an inflatable silicone ring around the proximal stomach connected to a subcutaneous port that allows for percutaneous adjustment of the band's tightness. Patients with previous upper gastric surgery or severe GER are generally poor candidates. The technique involves carefully dissecting a tunnel behind the upper stomach through which the band is passed and then locked into a ring configuration. A crucial step involves securing the band more firmly using the pars flaccida technique, which significantly decreased the incidence of band slippage and prolapse, a major complication with earlier methods. The band's tubing is then brought out to a port secured under the skin, allowing for fluid adjustments and follow-up visits. Regarding procedure-specific complications, LAGB has its own set of unique challenges: gastric prolapse, slippage. This is the most common emergent complication requiring reoperation. It presents acutely with severe pain and inability to eat. Initial treatment is removing fluid from the band. If that doesn't work, surgical reduction is needed. Band erosion. Uncommon, 1% to 2%, but serious. It means the band has eroded into the stomach. Diagnosis is usually by endoscopy. Treatment involves laparoscopic band removal and repair of the stomach. Port and tubing complications. Quite frequent, 5% to 15% of patients, including issues like leaks, kinks, or port inversion, often requiring minor repair. Failure to lose clinically significant weight. This is more common with LAGB than with other procedures. Consequently, the incidence of band removal for patient dissatisfaction or lack of weight loss is increasing. One study reported a 40.9% removal rate at 10 years. The key takeaway for LAGB is its relatively low initial surgical risk compared to other procedures, but it carries a higher long-term reoperation rate, mainly due to mechanical issues or insufficient weight loss. Its declining use reflects the greater efficacy and durability of other procedures.
Moving to the most complex and nutritionally impactful procedures, let's discuss biliopancreatic diversion and duodenal switch, or BPD-DAS. These are not as commonly performed, but their profound metabolic effects are undeniable.
Right. Biliopancreatic diversion, BPD, first described in Italy, involves resecting the distal stomach and rerouting a significant portion of the small intestine to minimize nutrient absorption. Its utilization has been limited due to both its technical difficulty and the significant percentage of severe nutritional complications that arise. An early problem was a high incidence of marginal ulcers. This led to the adaptation of the duodenal switch, DS, which is now simply called DS. It accounts for less than 1% to 2% of bariatric operations in the U.S. today. Patients considering BTD or DS must be thoroughly prepared for the consequences of a highly malabsorptive operation, including frequent large bowel movements after eating. They must commit to close, lifelong follow-up, and rigorous adherence to a large number of vitamin and mineral supplements to avoid severe nutritional problems. Due to the increased risk of complications, BPD and DS are typically reserved for patients with higher BMIs or those who have failed other weight loss metabolic operations. Contraindications include geographic distance from the surgeon, lack of financial means for supplements, and pre-existing severe nutrient deficiencies. The technique for DS is technically challenging. It begins with creating a sleeve gastrectomy by removing most of the stomach along its greater curvature. Then the duodenum, the first part of the small intestine, is divided just beyond the pylorus. The end of this divided duodenum is then connected directly to the distal small intestine, typically 250 centimeters from the end. The remaining bypassed small intestine, carrying bile and pancreatic enzymes, is connected even further down, about 100 centimeters from the ileocecal valve. Prophylactic gallbladder removal is also common due to the high incidence of gallstone formation. Regarding complications, BPD and DS share risks with RYGB, like bleeding and leakage. However, nutritional complications are by far the most frequent and concerning long-term issues. Protein malnutrition can occur in several percent of patients and is the most severe and life-threatening. Iron deficiency, anemia, and bone demineralization are also common. When protein malnutrition is severe, it may even require surgery to lengthen the common channel, the small intestine, where nutrients are absorbed, to improve absorption, though this is rarely necessary. The key takeaway for BPDS is its unmatched efficacy for weight loss and diabetes resolution. But this comes with the highest surgical complexity and the most significant long-term nutritional challenges, demanding absolute patient commitment to lifelong follow-up and supplementation.
That's a powerful reminder of the nutritional trade-offs with malabsorptive procedures. Beyond the established surgeries, the field of bariatric surgery is constantly innovating. What's at the cutting edge, and what do investigational procedures look like for the future?
The field is incredibly dynamic, continuously evolving. The goals for investigational procedures are clear: minimize risk, reduce invasiveness, and maximize clinical effectiveness. These emerging options often aim to fill the intermediate space in treatment between lifestyle modification and traditional bariatric surgery, often for patients with BMIs between 30 and 40 km. One such area is vagal nerve block therapy. The vagus nerve is crucial for satiety and metabolism. This therapy involves a laparoscopic procedure to attach electrodes to the vagal trunks at the esophagus. These electrodes are connected to a rechargeable neuroregulator placed under the skin. Published results show modest but sustained weight loss, with the device demonstrating safety and low serious complications. Endoscopically placed intragastric balloons, or IGBs, are also making a comeback. The original balloons in the 1980s had issues, but newer saline-filled IGBs are placed and removed endoscopically. They've shown significant weight loss compared to control groups. While some patients experience early removal due to intolerance or gastric ulcers, their precise role is still being determined. They must be combined with diet and exercise, and proper follow-up is crucial. Another investigational approach is an endoscopically placed percutaneous gastrostomy tube. This device facilitates the drainage of about 30% of consumed calories after a meal, combined with lifestyle counseling. In trials, patients using this device lost significantly more weight than controls. The most frequent complications are abdominal pain and irritation around the tube site. The duodenal jejunal bypass liner, or DJBL, is an endoscopic device designed to mimic the small intestine bypass component of RYGB. While still in trials, prior studies have shown modest weight loss and improvements in blood sugar control. However, adverse events like device migration and obstruction led to high early removal rates. Various other endoscopic and endoluminal procedures are being explored, such as methods to decrease gastric pouch size or limit the connection after failed RYGB, though effectiveness has been disappointing. Gastric plication, which mimics a sleeve gastrectomy without stapling, is also under investigation. Ultimately, all these require robust long-term safety and efficacy data before routine clinical use. This space is a testament to the ongoing pursuit of less invasive yet effective solutions.
So the surgery is done, but the journey is far from over. This is truly a lifelong commitment, isn't it? What does this crucial ongoing care look like, and what are the specific aspects of postoperative follow-up?
It absolutely is a lifelong commitment. Postoperative follow-up is not just recommended, it's required to detect and treat both short and longer-term complications. Issues like weight regain, internal hernias, ulcerations, and particularly important nutrient deficiencies can emerge years after the initial procedure. The frequency of follow-up varies by procedure and practice, but ideally it continues for life. For most procedures, recommendations suggest at least 75% of patients are followed for 5 years, increasing to 90% for more malabsorptive operations like BPDDS. One of the significant challenges here is patient compliance with long-term follow-up. While a clinical system may be in place, studies show that generally long-term follow-up rates are low in research settings. Improving this requires vigorous efforts, significant staffing, and funding. The NIH-funded lab study, for instance, achieved high completeness for RYGB patients in the longer term by investing these resources. The goals of follow-up evolve. In the short term, 0 to 2 years, the focus is on maximizing patient care, assisting with adjustment to new eating, exercise, lifestyle patterns, being vigilant for complications, and recommending measures to limit them. In the long term, beyond 2 years, the focus shifts to addressing weight regain, managing comorbidity relapse, detecting recurrent depression, substance alcohol misuse, and, crucially, nutritional complications. Nutritional monitoring is a cornerstone of lifelong care. Patients are required to take daily oral supplements, iron, calcium, B12, and a multivitamin for the rest of their lives. Deficiencies in calcium, vitamin D, iron, zinc, and copper are particularly common. Guidelines recommend screening for these deficiencies preoperatively. Postoperatively, specific daily supplementation is vital. Beyond daily supplements, all patients should undergo annual screening for specific deficiencies. Objective data obtained during follow-up includes tracking weight loss, BMI changes, resolution of medical comorbidities, and any complications. Quality of life assessment also helps gauge efficacy. Studies have shown the direct impact of consistent follow-up. For example, a large review linked complete follow-up to greater weight loss and higher rates of comorbidity improvement. For LRYGB patients, frequent protocolized band adjustments and support sessions are particularly important for long-term outcomes. The 12-month visit is often a critical juncture, coinciding with the plateauing of weight loss, offering a key opportunity for intervention. Engaging patients and leveraging technology are vital to maintaining consistent contact and ensuring compliance with this lifelong journey. Despite all this, there are still unmet needs, such as optimal dietary and nutritional management for specific complications like chronic nausea, hypoglycemia, or anastomotic ulcers.
Okay, so after all this meticulous preparation, complex procedures, and ongoing care, what are the results? Do these surgeries actually deliver on their promise, both in the short and long term?
The evidence base is robust and increasingly clear. Let's start with the short-term outcomes, typically within 1 to 2 years post-surgery. The average 30-day mortality is remarkably low across almost all procedures, generally less than 1.0%. For LRYGB, it's consistently under 0.3% to 0.5%. Morbidity, or the rate of complications, varies by procedure, lowest for LRYG, then SG-LRYGB, and highest for BPDS. The LAF study reported a 4.8% major adverse outcome rate for LRYGB patients at 30 days. Regarding weight loss, the results are quite impressive. Total body weight loss, TBWL, at 1-2 years typically ranges from 31% to 36% for LRYGB, 25% to 30% for SG, and 36% to 38% for BPDS. Remission rates for dyslipidemia, hypertension, and obstructive sleep apnea are similarly high across procedures, generally in the 60-90% range for LRYGB, SG, and BPDS. SG is generally positioned between LRYB and LRYGB in terms of efficacy for weight loss, comorbidity resolution, and morbidity mortality. BPDS consistently delivers excellent and durable weight loss, with one 18-year follow-up study showing a mean excess weight loss of 70%. However, these benefits come with higher surgical morbidity and considerable nutritional complications.
Those short-term outcomes are compelling, but to truly gauge the value of these interventions, we need to compare them directly to non-surgical approaches. What does the evidence say about the effectiveness of bariatric surgery versus medical or lifestyle treatments?
Yeah, the comparison is quite stark. A systematic review of randomized controlled trials comparing bariatric surgery to non-surgical treatments for obesity found compelling evidence. Bariatric procedures resulted in significantly greater short-term weight loss, a mean difference of 26 kilograms, and profoundly greater remission of type 2 diabetes compared to various non-surgical treatments. For complete diabetes remission, the relative risk for surgery was dramatically higher. Beyond weight and diabetes, serum triglycerides were significantly reduced, and high-density lipoproteins were increased. Many studies also reported a reduction in medication use for blood pressure and other conditions. It's important to note a limitation. This review highlighted a lack of evidence from randomized trials beyond 2 years regarding long-term mortality, cardiovascular diseases, and adverse events. Another review specifically focused on class I obese adults, BMI 34.9 with type 2 diabetes. It found that surgical results for weight loss and glycemic control were similar to those seen in more severely obese populations, but again emphasized the need for longer-term studies in this group. The overarching message is clear. For significant durable weight loss and comorbidity resolution, surgery is far superior to non-surgical options alone.
Here's where the truly deep insights emerge. This short-term data is compelling, but the true test of any intervention for a chronic disease is its long-term impact. What about the long game? Do these benefits, especially for weight loss and comorbidity resolution, truly last for years, even decades, after surgery?
This is perhaps the most critical area of evidence. Fortunately, we now have substantial longer-term studies demonstrating the durable benefits of bariatric surgery. One of the most foundational is the Swedish Obese Subjects, or SOS, study. This prospective trial, initiated in 1987, compared surgical subjects against matched controls receiving usual care, with exceptionally high follow-up rates over 10 to 20 years. The SOS study definitively showed that weight loss in the surgical group was significantly greater and far more durable than in the control group. At 20 years, the surgical group maintained an 18% weight loss, while controls showed virtually no long-term change. Importantly, at 16 years of follow-up, surgery was associated with a 29% lower risk of death from any cause compared to usual care. The study also documented major improvements in obesity-related comorbidities, with a durable 36% remission of type 2 diabetes remaining at 10 years and a dramatically reduced risk of incident type 2 diabetes. While the study primarily included older procedures and was not randomized, its long-term follow-up is invaluable. The Utah obesity studies provide further compelling long-term data, primarily on LRYGB. A retrospective study showed a remarkable 40% reduction in all-cause mortality, 49% reduction in cardiovascular disease mortality, and an astounding 92% reduction in type 2 diabetes-related mortality over a mean follow-up of 7.1 years. A separate prospective Utah study demonstrated durable weight loss at 12 years, with LRYGB patients maintaining a nearly 27% total body weight loss. Type 2 diabetes was in remission in over half of LRYGB patients at 12 years, and the odds of incident T2DM were dramatically lower for the surgical group. Significant improvements in blood pressure and cholesterol were also observed. The Department of Veterans Affairs study found significantly lower all-cause mortality in the surgical group, primarily LRYGB, after both 1 to 5 years and 5 to 14 years of follow-up. This study also showed LRYGB patients lost significantly more baseline weight than non-surgical matches at 10 years. The Longitudinal Assessment of Bariatric Surgery, or LABAS study, is a crucial multi-center observational cohort. It found a very low overall 30-day mortality of 0.3% and low major adverse outcome rates. At 7 years, the median weight change was still substantial for LRYGB and LRYGB. Type 2 diabetes remission was seen in 60% of LRYGB patients at 7 years, and reoperations were much more common after LRYGB. This study provided excellent safety and effectiveness data, even if not randomized. Other important studies, like those from the HMO Research Network and the Michigan Bariatric Surgery Collaborative, have reinforced these findings, showing high rates of diabetes remission and overall comorbidity improvement, as well as providing valuable data on complication rates for different procedures. The MBSA QIP National Database has also consistently positioned SG's morbidity and effectiveness between LAGB and LRYGB. Collectively, these extensive long-term studies provide overwhelming evidence of durable weight loss, profound comorbidity resolution, and improved survival associated with bariatric surgery. This is what truly sets it apart as a treatment for severe obesity.
That's an extraordinary body of evidence. Given all these studies, how do the various procedures currently in use compare head-to-head in terms of their overall efficacy for weight loss and comorbidity resolution?
That's a critical question, and it's complex because no single randomized controlled trial has directly compared all the most common procedures, so we draw inferences from pooled analyses. We also still lack studies specifically examining differences in long-term survival or cardiovascular events directly across all bariatric procedures. Despite these challenges, some general patterns have emerged. Older meta-analyses found a clear hierarchy in weighted mean percentage of excess weight loss. LAGB achieved about 50%, RYGB 68%, and BPDDS led with 72%. A similar pattern was observed for type 2 diabetes remission rates, with BPDDS at an impressive 99%, RYGB at 84%, and LAGB at 48%. This pattern extended to dyslipidemia, hypertension, and obstructive sleep apnea, with BPDS showing the greatest remission, followed by RYGB and then LAGB. In the current landscape comparing LRYGB, SG, and LAGB, systematic reviews consistently show that LRYGB is more effective for weight loss than LAGB. Recent reviews comparing SG to other procedures found that SG's excess body weight loss ranged significantly, generally between LRYGB and LAGB. For type 2 diabetes remission, SG rates also varied, but often fell between RYGB and LAGB. While LRYGB often achieves slightly greater BMI improvement and metabolic factor improvement than SG, the prevailing conclusion is that the effectiveness of the SG procedure appears to be positioned between that of LRYGB and LGB. We still need more robust, longer-term comparative data for SG to fully understand its long-term profile.
What's fascinating here is how many other obesity-related health issues, beyond just weight and diabetes, can be resolved or significantly improved by these surgeries. It's a much broader impact than many realize.
Absolutely. The benefits extend across a wide spectrum of health conditions. For cardiovascular disease, bariatric surgery leads to significant excess weight loss and high rates of remission or improvement for hypertension, type 2 diabetes, and hyperlipidemia. While no long-term randomized trials exist specifically for CVD outcomes, most large observational studies consistently show a reduced cardiovascular event rate and all-cause mortality, with the SOS study providing the longest outcomes. Gastroesophageal reflux disease, GED, is another area of significant impact. Obese patients with GEORD often have higher failure rates with standard anti-reflux surgery. LRYGB is highly effective for GEORD treatment as it creates a small pouch with limited acid production, leading to better symptom improvement. LRGB's impact on GERD is variable. In contrast, studies consistently show that SG can actually increase GERD symptoms postoperatively due to the high-pressure gastric tube it creates. This is a critical factor in patient selection for SG. Obstructive sleep apnea, OSA, sees significant improvement or resolution in over 75% of bariatric surgery patients. BPD and RYG offer the most benefit, while LIG shows the least. For patients with asthma, surgery has been shown to lead to significant improvements in asthma control, lung function, and quality of life. Non-alcoholic fatty liver disease, NAFLD, a metabolically related problem common in obesity that can progress to cirrhosis, is also impacted. While more research is needed, some reports support the role of bariatric surgery as a potential treatment, though systematic reviews have found observational studies but no randomized trials to date. Musculoskeletal diseases, such as degenerative joint disease and low back pain, are very common in severe obesity. LRYGB has been shown to significantly improve musculoskeletal function. Patients with osteoarthritis in various joints experience improved or resolved joint pain after bariatric surgery, with reductions in BMI correlating to significant pain resolution. Finally, regarding quality of life, while long-term studies are limited, those of 6 to 10 years suggest that bariatric procedures improve overall and obesity-specific quality of life compared to medical treatment. Physical functioning aspects tend to improve more significantly than mental health domains, highlighting areas for further research.
So what does this all mean for one of the most critical comorbidities, type 2 diabetes? It seems almost like a cure for some, and the field has even rebranded part of this as metabolic surgery. How profound are these results, and what is the latest guidance for its use?
The impact of bariatric surgery on type 2 diabetes is truly revolutionary, which is why it's increasingly referred to as metabolic surgery. Observational studies first demonstrated these profound improvements, and these findings are now robustly supported by randomized controlled trials. Remission is typically defined as a patient becoming non-diabetic, with normal HbA1c levels without needing medications. Early meta-analyses already reported an overall T2DM remission rate of 78% after surgery. The landmark SOS study reported a 72% remission rate at 2 years and a durable 36% remission at 10 years in the surgical group, dramatically outperforming control groups. Importantly, metabolic surgery also significantly reduced the risk of new-onset T2DM by 78%. More recent systematic reviews evaluating long-term cardiovascular risk reduction found that surgery led to high rates of T2DM remission or improvement, and critically, 12 cohort-matched studies consistently demonstrated reduced cardiovascular events and death in surgical patients. These observational data collectively provide compelling evidence that metabolic surgery is superior to medical management alone for glycemic control, reducing cardiovascular risk factors, and lowering long-term morbidity and mortality from T2DM. The most powerful evidence comes from 11 randomized controlled trials published over the last decade. These trials included various procedures and covered varying degrees of T2DM severity and BMI ranges, with most studies including patients with class I obesity, BMI less than 35 kilometers of away. The primary endpoint in most was remission. Overall, these trials conclusively showed that surgery was significantly more effective than medical treatment in achieving remission and glycemic control. Surgery decreased HbA1c by 2% to 3.5%, while medical treatment achieved only 1% to 1.5% reduction. Most studies also demonstrated surgery's superiority in achieving secondary endpoints, including greater weight loss, remission of metabolic syndrome, reduction in diabetes and cardiovascular medications, and improvements in lipids and quality of life. Crucially, nearly all trials showed that surgical procedures, especially LRYGB and SG, were equally effective in patients with class I obesity, BMI 30 to 55 kilometers, and these effects have proven durable for at least 5 years. While these trials were not powered to detect differences in macrovascular or microvascular complications or death, the evidence is strong for metabolic improvements. The weight of this evidence has led to the establishment of new international guidelines on metabolic surgery. The Second Diabetes Surgery Summit, DSS-2, and the American Diabetes Association's 2017 Standards of Care now recommend metabolic surgery for type 2 diabetes in patients with class 3 obesity, BMI of 40 kg minute control. It's also recommended for class 2 obesity, BMI 35.0, 39.9 kg minute when blood sugar is inadequately controlled. For class I obesity, BMI 30.0, 34.9 kg minute surgery should be considered if hyperglycemia remains inadequately controlled despite optimal oral or injectable medications. These BMI thresholds are further reduced for Asian patients. This new treatment algorithm truly integrates lifestyle, drug therapy, and surgery as appropriate tools in a comprehensive management plan.
Okay, every major medical intervention comes with risks and trade-offs. While the benefits of bariatric surgery are clear, it's essential to have a frank discussion about the complications, both surgical and non-surgical, that patients might face.
You're absolutely right. No surgical procedure is without risks, and transparency about complications is paramount. The perioperative mortality for the average bariatric patient is remarkably low, consistently less than 0.5% and continuing to decline. However, it can be higher in certain high-risk patient subgroups. The overall incidence of complications varies depending on the definition, procedure, and patient characteristics. Randomized controlled trials generally show higher adverse events in surgical groups compared to non-surgical treatment, with common issues being iron deficiency, anemia, and the need for reoperations. The LABS study found a 30-day mortality rate of 0.3% overall and a major adverse outcome rate of 4.1%. Predictors of increased risk in labs included a history of venous thromboembolism, obstructive sleep apnea, impaired functional status, extreme BMI, and undergoing an LRYGB by the open technique. Older studies, like SOS, reported higher overall complication rates but largely involved older procedures. Later meta-analyses and large U.S. studies confirm low mortality but highlight overall complication rates. A useful risk score for LRYGB identifies patients with multiple factors like high BMI, male sex, hypertension, and age over 45 as having a much higher risk of death. For sleeve gastrectomy, complication rates are generally positioned between LHGB and RYGB. A significant issue that has emerged is the frequent rate of reoperation, particularly after LHGB. One large study reported a 29% revisional surgery rate for LHGB patients, with issues like gastric prolapse and port problems being common. Some cohorts show LHGB removal rates up to 50%. While LRYGB also has revisional surgery rates, the LABS study showed a consistently higher rate of revision and reoperation for LHGB compared to RYGB at both 3 and 7 years of follow-up. Now let's turn to non-surgical complications, which are equally vital for comprehensive care. Post-gastric bypass hypoglycemia, PGBH, is an uncommon but challenging problem, occurring in 1% to 11% of patients. It's characterized by low blood sugar symptoms with inappropriately high insulin levels after eating. While initially linked to pancreatic changes, current thinking relates it more to altered physiology after surgery, possibly due to increased GLP-1. Treatment primarily involves dietary changes, reducing high glycemic index carbs, and specific medications. Complete gastric bypass reversal or pancreatic resection are generally not uniformly successful. For pregnancy complications, studies show bariatric surgery is associated with reduced risks of gestational diabetes and excessive fetal growth. However, there's also an increased risk of small for gestational age infants and preterm birth. Emerging data suggests a greater long-term risk of substance and alcohol use disorders, SUD, after some procedures, particularly RYGB. Pharmacokinetic studies show altered alcohol absorption leading to higher blood alcohol concentrations from small amounts. Studies like SOS and LABS have shown increased alcohol consumption and AUDs in RYGB patients, with AUD symptoms reported by 20% within 5 years. There is also concern about an increased risk for suicide and self-harm after bariatric surgery, although the etiology is unclear and data complex. Studies have shown an increase in non-disease-related causes of death, including suicide, in surgical groups compared to controls, with many events occurring in the first few postoperative years. Finally, nutritional deficiencies are common long-term complications. Deficiencies in calcium, vitamin D, iron, zinc, copper, and others are frequently observed. Guidelines recommend screening for these preoperatively, and lifelong daily supplementation and routine long-term monitoring are crucial. A concerning trend is that while the incidence of deficiencies is increasing, consistent monitoring is often decreasing. There is also insufficient evidence on optimal dietary management for some specific postoperative complications like chronic nausea, hypoglycemia, or anastomotic ulcers.
So, like other chronic diseases, sometimes one surgery isn't the end of the story. What happens when a patient experiences insufficient weight loss, or significant weight regain, or develops a severe complication requiring another procedure? What does the growing field of reoperative or revisional bariatric surgery entail?
That's a crucial insight for professionals. Just like with joint replacements or heart bypasses, obesity, being a chronic disease, often necessitates additional or revisional surgical procedures when the primary intervention doesn't sufficiently achieve its long-term goals or leads to complications. With millions of bariatric surgeries performed globally, reoperative surgery has become increasingly prevalent. Revisional surgery is typically indicated in two main situations: for insufficient weight loss or weight regain, and for the treatment of acute or chronic complications. While many effective revisional procedures exist, there's currently no definitive data-driven evidence to guide which specific patient will benefit most from a revision, nor a consensus on the single most optimal revisional approach. The principles guiding reoperative bariatric surgery emphasize a critical risk-benefit evaluation. Weight loss after revisional procedures tends to be less than with the primary procedure. While reoperations are associated with higher morbidity and mortality compared to primary procedures, these risks are acceptably low with careful patient selection and experienced surgeons. In some cases, a two-stage approach, for example, removing a failed band, allowing healing, then performing a conversion, may be considered. When evaluating a patient for revisional surgery, the absolute priority is to clearly establish the reason for the revision. Is it a surgical complication, insufficient weight loss, or weight regain? Is there an anatomical cause? For weight loss or gain issues, it's vital to determine if behavioral or other non-surgical modifications could help, and if the patient is truly committed. The focus for revisional surgery often shifts less on achieving a specific absolute weight loss, and more on improving comorbidities and quality of life. The comprehensive preoperative evaluation must include a review of the initial operative note, anatomical evaluation, extensive nutritional assessment, and a behavioral health evaluation for insufficient weight loss or weight regain. Vertical banded gastroplasty, VBG, often converted safely to RYGB and SG. Adjustable gastric band, LRYGB. Increasing reports of failure or disappointing weight loss. Removal without another bariatric procedure often leads to significant weight regain. Conversion to SG, RYGB, or BPDDS generally shows good outcomes. Sleeve gastrectomy, SG. About 5–10% may require revision for poor weight loss. Conversion to RYGB and BPDS is supported. Roux-en-Y Gastric Bypass, RYGB. About 10–20% have inadequate weight loss regain. Options include banding over the bypass, revising the pouch, or limb lengthening. Endoscopic revisions to reduce pouch size have shown short-term success. For the treatment of surgical complications, vertical banded gastroplasty, VBG, complications like wide outlet, pouch dilation, or staple line issues usually lead to conversion to RYGB. Adjustable gastric band, LAGB. Complications like gastric prolapse, band erosion, or port problems may necessitate removal or conversion to SG, RYGB, or BPDDS. Sleeve gastrectomy, SG. Staple line leaks, sleeve stricture, or persistent GRA. Strictures are usually treated with endoscopic dilation, but persistent issues may require conversion to RYGB. Complications include pouch anastomosis, dilation stricture, ulcers, or internal hernias. Revision focuses on the specific complication. Complete reversal of RYGB is rare, reserved for severe cases, but often leads to significant weight regain. Biliopancreatic diversion with duodenal switch, BPDDS. The most severe chronic complication is protein-calorie malnutrition. Management involves meticulous nutritional evaluation and support, with surgery to lengthen the common channel as a fallback option.
Beyond the procedures themselves and their direct complications, there are unique considerations for certain patient populations, and also how this entire field impacts our broader healthcare system. What are these special issues in bariatric surgery?
This is a crucial segment that puts bariatric surgery into a broader context, truly moving to a professional level of understanding. Let's start with bariatric procedures in adolescence. There's been historical controversy stemming from a general aversion to surgery in adolescents and concerns about potential side effects on their growth and development. However, the frequency of adolescent bariatric surgery has increased, though it remains lower than in adults. Much of the early data was extrapolated from adults, underscoring the need for more specific evidence on long-term weight loss, durability, and complications in this age group. A meta-analysis of adolescents showed significant BMI decreases after RYGB, with high rates of hypertension improvement and OSA resolution. Nutrient deficiencies were the most common complication. The ASMBS pediatric guidelines now recommend considering surgery for adolescents with a BMI of 35 or greater with major comorbidities, or 40 or greater with minor ones. The Teen Lab study, a long-term prospective study of adolescents, provides invaluable data. At 3 years, weight loss was substantial, and remission rates for T2DM, abnormal kidney function, and elevated blood pressure were remarkably high, often higher than those seen in adults. However, risks like iron deficiency and the need for additional intra-abdominal procedures highlight that while benefits are significant, longer observation is warranted. Next, let's consider cost effectiveness. For adolescents, limited evidence suggests superior weight loss and comorbidity resolution compared to non-surgical interventions. While specific cost-effectiveness data is scarce, evidence suggests bariatric surgery can become cost-effective several years post-intervention, rather than immediately. For adults, the debate continues on whether surgery reduces overall healthcare expenditures enough to achieve cost savings. While an older study suggested decreased long-term direct healthcare costs, more recent large observational studies found no evidence of overall cost savings. Outpatient costs are generally reduced, but long-term inpatient costs tend to be increased or unchanged, meaning no long-term net cost benefit is typically achieved for the healthcare system. It is likely cost-effective, provides good value for health improvements, but doesn't necessarily produce savings. Quality assurance is another crucial aspect. As laparoscopic bariatric surgery rapidly increased, safety concerns led to the development of accreditation programs like ASMBS Center of Excellence, COE. These programs verify centers have necessary infrastructure, experienced staff, and report outcome data. In 2012, these merged into the Metabolic and Bariatric Surgery Accreditation and Quality Improvement Program, MBSA QIP, a rigorous program that collects validated prospective outcome data. Centers use this data for quality improvement. This accreditation has been associated with improved outcomes, including length of stay, mortality, and morbidity. Finally, a significant issue for many patients is plastic surgery after weight loss. After massive weight loss, patients are often left with substantial skin and subcutaneous tissue deformities, which can cause rashes, maceration, and impact quality of life. Plastic and reconstructive surgery is now recognized as an integral part of the continuum of care. It's typically deferred for 1 to 2 years post-op until weight stability to ensure optimal healing. Common areas addressed include the lower torso, abdominoplasty, body lift, and upper body, breast reshaping. Some studies suggest that improved body image from corrective surgery may positively affect long-term weight maintenance.
So, what does this all mean? We've covered a vast landscape of knowledge, from the rudimentary origins of bariatric surgery to its current sophisticated state, exploring its profound metabolic impact and the meticulous patient journey. But the journey of discovery continues. What are the most pressing, high-priority questions that future research in this field needs to address?
It's clear that while tremendous strides have been made, particularly in the last decade, there remains a significant amount to uncover. For a truly elite understanding, these are the high-priority questions that future research will focus on. Firstly, we still need a more precise understanding of the specific mechanisms of action responsible for both the weight loss and the type 2 diabetes response to bariatric surgical procedures. Pinpointing these will open doors for even more targeted therapies, perhaps mimicking surgery without the invasiveness. Secondly, identifying patient-level factors that predict success is crucial. What specific preoperative and postoperative behaviors, as well as biological markers, can reliably predict success with weight loss, sustained health improvements, and potentially even cost savings after bariatric surgery? This would allow for even more personalized treatment approaches. Thirdly, for patients with class I obesity, BMI 35, we need definitive long-term data on whether bariatric surgery is more effective than non-surgical care for type 2 diabetes. While short-term trials show promise, robust longer-term evidence is still needed in this specific population. Fourth, with more standardized reporting of complications, we need to precisely delineate the long-term complication rates after each different bariatric procedure. This consistent data is vital for informed patient counseling. Fifth, a critical question is the effect of bariatric surgery on long-term microvascular and macrovascular event rates. While observational data is promising, definitive randomized trial data on these hard outcomes, things like heart attacks or strokes, would be transformative. Finally, there's an urgent need to understand the comprehensive reproductive and mental health outcomes following bariatric surgery, including the often complex and underreported risk for self-harm and suicide, alcohol use disorders, substance abuse, and other risk-taking behaviors.
It's clear that while we've made incredible strides, transforming rudimentary, often dangerous, procedures into sophisticated, life-changing interventions, there's still so much to learn. It's a field constantly evolving, driven by high-quality evidence, pushing the boundaries of our understanding of human physiology and disease. You've just completed a truly deep dive into the surgical management of obesity, moving from its earliest rudimentary forms to the incredibly sophisticated, multidisciplinary interventions we see today. You've explored not just what happens, but why it matters, and the complex interplay of anatomical, physiological, and even behavioral factors that make these procedures so powerful. We've aimed to give you a truly elite understanding, much like a professional in the field.
If we connect this to the bigger picture, Consider how deeply interconnected our physiology, psychology, and even social support systems are in the journey of health, particularly when facing a complex, multifactorial disease like obesity. The very evolution of bariatric surgery, from simple anatomical changes to its profound systemic metabolic effects, forces us to continually redefine what healing truly entails and how intertwined physical intervention is with comprehensive lifestyle and mental well-being. It's a powerful lesson in holistic health.
We hope this deep dive has given you that aha moment and equipped you with knowledge like an elite professional in the field. Keep that curiosity sparked, because there's always more to learn.